Imagine stepping into an environment where human biology is actively failing. Alarms are screaming, monitors are flashing red, and the sheer volume of data points hitting your senses is just overwhelming.
Oh yeah, it is a complete sensory overload.
Right, and in this space, every single second that ticks by dilutes your window to make a life-saving decision. Usually when people think about high-stakes decision-making or arriving at a medical diagnosis, they picture this process of mechanical precision.
They do. They imagine something like taking a broken car to an automotive mechanic, you know?
Exactly. You hook the car up to a computer, it spits out a highly specific error code, you replace the alternator, and the machine runs perfectly again.
Right.
We really crave that binary, clear-cut answer.
We crave it, absolutely. But the problem is that the mechanic metaphor just disintegrates the moment you step onto a hospital floor.
How so?
Well, a broken car does not experience agonizing fear when its engine stalls, right? An automobile does not have a cascading, catastrophic failure of its electrical system simply because you change the oil.
That is a very good point.
In healthcare, you are dealing with living, breathing, deteriorating organisms. Their internal chemistry and their psychological states are constantly colliding. So the landscape is incredibly dynamic, completely unpredictable, and often shrouded in diagnostic fog.
Which means relying on a simplistic binary mindset is not just ineffective, it is actively dangerous. You are looking at a human being whose physiological condition can invert in a matter of minutes.
Literally minutes, sometimes seconds.
So how do nurses navigate that chaos? How do they make split-second decisions without falling victim to cognitive overload? Or worse, just reacting blindly to whichever machine is beeping the loudest?
Well, it certainly is not magic. And it is not just some mystical intuition they pull out of thin air either.
Right, because intuition without structure is just a guess.
Exactly. And you cannot build a reliable healthcare system on guesswork. What allows a nurse to function in that environment is a highly structured, purposeful, and disciplined architecture of thought.
A cognitive framework.
Yes, a cognitive framework designed to short-circuit the human brain's natural tendency to panic or just make assumptions.
Welcome to the Nursing Launchpad program, right here on the Licensed Practical Nurse Launchpad channel. I am so glad you are joining us today.
We have a really vital mission for this discussion. We are going to completely unpack the cognitive machinery that keeps patients alive.
We really are. We are exploring the concept of critical thinking in a clinical environment. And we are going to walk you through the ultimate framework built upon that concept, which is the 6 sequential phases of the nursing process.
Our objective is to totally demystify the mechanics of clinical reasoning. We are moving far beyond just the mere memorization of physiological facts today.
Because having a vast mental library of medical knowledge is a prerequisite. Naturally, you have to know the facts.
Of course. But what we are dissecting today is the algorithm of execution. We are examining how that knowledge is weaponized in real time.
To ensure every single patient receives individualized, highly targeted, and profoundly safe care.
Precisely. So let's start with critical thinking itself.
Yeah, because we hear the phrase critical thinking tossed around constantly, right? In corporate boardrooms, in software development, in academic debates.
It is a major buzzword.
It really is. But when we transition into a healthcare setting, that phrase takes on a totally different weight. It is often described as thinking with a purpose.
Yes, thinking with a purpose. I love that definition.
Let's establish the boundaries here, though.
Yeah.
How does the discipline of nursing uniquely define critical thinking, say, compared to how a software engineer might define it?
Well, in a clinical context, critical thinking is fundamentally a discipline-specific, highly reflective reasoning process.
Okay, unpack that a little bit.
It is the cognitive engine that drives a practitioner through the generation, implementation, and rigorous evaluation of approaches to patient care.
So it's constantly moving.
Right. A software engineer might use critical thinking to optimize a line of code for speed, but a nurse uses critical thinking to constantly question the physical reality in front of them.
You are actively engaging with the patient's presentation.
Exactly. You are interrogating your own assumptions, and you are applying this massive repository of scientific knowledge to alter the trajectory of their health.
Let's talk about the friction between general thinking and critical thinking. Because let's be honest, our brains are naturally lazy.
Oh, absolutely. Psychologists often talk about cognitive ease.
Right, the brain's desire to take the path of least resistance. General thinking is kind of like floating aimlessly down a wide river.
That is a great analogy.
You are in the water, you are moving forward, but the current is entirely dictating your path. You might have spontaneous thoughts, Perhaps a vague sense of worry about the rapids you hear in the distance?
But you possess zero navigational control.
Exactly. Critical thinking, by contrast, is paddling a canoe upstream. You are equipped with a topographical map, a compass, and a hyperspecific destination.
And let me tell you, the metabolic cost of critical thinking is incredibly high, which is exactly why we have to constantly train ourselves to do it. The brain wants to float.
Give me a real-world example of that, outside of the hospital first.
Sure. Consider a scenario where someone is preparing to begin a highly demanding new career. General thinking manifests as passive, cyclical anxiety.
So just worrying on the couch.
Right. They sit on their couch the night before, their heart rate is elevated, and they are just thinking, am I going to fail? What if the traffic is horrendous? What if I cannot locate my department?
That is massive mental activity, but it lacks any actual utility. It is just processing power being burned on fear.
It is entirely reactionary. The environment is acting upon them.
Right, so how do we inject critical thinking into that exact same scenario?
Well, the individual acknowledges the anxiety, but then they pivot to purposeful action. They think, okay, my primary risk factor for failure tomorrow is the unpredictability of the commute.
So they take control of the variables they can.
Precisely. They say, therefore, I will drive the entire route today during peak rush hour. I will time the traffic patterns. I will physically locate the parking structure, and I will find the fastest walking route to my department.
That is thinking with a purpose.
Yes. It identifies a clear vulnerability, which is lateness and the resulting panic, and it generates a logical, actionable, preemptive solution.
Taking that framework into a clinical setting, a nurse is not just floating through a grueling 12-hour shift, reacting to call bells. They are strategically navigating.
But here is the inescapable truth about that navigation. You cannot critically think about a subject if your internal database is empty.
Right, you cannot synthesize a solution if you lack the raw materials. Critical thinking absolutely requires a foundational bedrock of hard scientific knowledge.
We are talking about deep, granular understandings of anatomy, cellular physiology, and pharmacokinetics. It is an absolute non-negotiable prerequisite.
Because you can't critically analyze a deteriorating patient if you do not understand the underlying mechanical failure of the organs you are observing.
Exactly. If a patient presents with sudden, severe edema or swelling in their lower extremities, a critical thinker does not just see swollen legs.
What do they see?
They immediately visualize the cardiovascular system. They consider the hydrostatic pressure in the capillaries, the potential failure of the right ventricle to pump effectively.
Or perhaps a severe depletion of plasma proteins altering oncotic pressure.
Right. As this knowledge base solidifies, a nurse moves from merely observing symptoms to projecting future clinical trajectories across a multitude of unique patient scenarios.
It changes the practitioner from being someone who treats symptoms to someone who manipulates complex biological systems.
And it requires a very specific type of personality to wield that knowledge effectively. A true critical thinker in healthcare is highly introspective.
They are acutely aware of their own cognitive biases.
Yes, they know when they are tired, they know when they are frustrated, and they recognize how those internal states might skew their clinical judgment.
They also possess a relentless curiosity, constantly asking why at every juncture.
Why has this specific evidence-based practice guideline been updated? Why did my intervention fail to produce the anticipated physiological response in this specific patient?
They view every clinical encounter, every unexpected variance, and especially every error, as raw data to refine their internal algorithms. They are intellectually flexible.
Very flexible. They are willing to abandon a deeply held assumption. The absolute moment objective data contradicts it.
I want to challenge this concept of relentless introspection for a second, especially in the context of modern healthcare.
Okay, go for it.
Picture a wildly understaffed emergency department. You have a patient hemorrhaging in Bay 1, a psychiatric crisis in Day 2, and a critical respiratory failure arriving via ambulance.
A standard Tuesday, right?
Yeah, exactly. Does this constant internal questioning, this demand for deep reflection, not inherently slow a practitioner down?
That is a very common concern.
Because when speed is the primary currency of survival, isn't there a danger in overthinking?
It is a common misconception that critical thinking is slow and cumbersome. But in reality, a lack of critical thinking is what causes catastrophic delays. Yes, the cognitive process takes a fraction of a second longer than a sheer knee-jerk reaction, but that fraction of a second is what prevents lethal errors.
Because in a high-stakes environment, The brain naturally defaults to heuristics, right?
Yeah.
Mental shortcuts based on pattern recognition.
Exactly. And the danger is that if you rush and make a clinical decision based on a flawed assumption, you are in trouble.
Like assuming a patient's confusion is due to intoxication rather than extreme hypoxia.
Exactly. If you make that assumption, you will apply the wrong intervention, you will waste precious time, and you will likely kill the patient.
Speed without accuracy is fatal.
A critical thinker understands that they possess the discipline to persevere, to cut through the noise, and to find the correct physiological solution, not just the most obvious one.
It is the architectural difference between a trained sniper and someone just firing a machine gun blindly into the dark. Precision always trumps pure, uncontrolled speed.
It always does.
So the ultimate question becomes, how do we operationalize this?
That is the big question.
How does a practitioner take this abstract philosophical concept of purposeful thinking and translate it into a tangible, repeatable system at the bedside?
You operationalize it through a highly structured algorithm known as the nursing process.
Ah, there it is.
Yes,
Yeah.
this is the universally accepted, systematic problem-solving methodology that empowers nurses to identify complex patient vulnerabilities.
And to plan, deliver, and rigorously evaluate clinical care using a scientific framework.
It is the literal vehicle through which critical thinking is deployed in a hospital.
When people hear the word process, though, they instantly think of a rigid, linear checklist.
Right, like assembling furniture.
Exactly. The kind of thing you use to build a bookshelf. Step 1, step 2, step 3, and then the job is finished.
Mm.
But applying a linear checklist to human biology seems like a massive recipe for disaster.
Because human biology is not linear at all.
Not even a little bit.
The most critical conceptual hurdle to overcome is understanding that this process is a dynamic, continuous, and infinitely adapting circle. It is a feedback loop.
Because a patient's physiological status is constantly fluctuating. You might complete your initial assessment and formulate a flawless plan, but 10 minutes later, the patient's blood pressure collapses.
And suddenly the linear checklist is completely useless.
Right.
The dynamic circle demands that you immediately loop back to the beginning, gather the new data, and rewrite the entire strategy in real time.
Let's map out the perimeter of this circle before we dive into the specific mechanics of each phase.
Sure. The framework is divided into 6 distinct yet entirely overlapping phases,
We begin with assessment,
followed by diagnosis,
then outcomes identification.
planning, implementation, and finally, evaluation.
Now, I know some frameworks seamlessly blend outcomes identification and planning into a single strategic phase, but the core logic remains identical, right?
Absolutely. The foundational logic does not change.
It is also vital to understand the tactical deployment of personnel within this framework. Healthcare is not a solitary endeavor.
No, it is a highly coordinated team operation. The roles within this process are strictly defined yet highly symbiotic.
So who does what?
Well, the registered nurse acts as the strategic command. They are legally responsible for the initial, highly comprehensive admission assessment.
And they hold the responsibility for formulating the formal diagnostic statements.
Right. But a strategic command is completely blind without tactical operators constantly feeding intelligence back from the field.
And that is where the licensed practical nurse enters the architecture.
Exactly. The licensed practical nurse is the tactical operator maintaining continuous contact with the patient.
They are executing focused, ongoing assessments minute by minute.
They are actively contributing to the evolution of the care plan. They are physically carrying out the critical interventions during the implementation phase, and they are constantly evaluating whether the patient is moving toward or away from the established physiological goals.
So the registered nurse may draft the initial architectural blueprint, but the licensed practical nurse is the one constantly analyzing the structural integrity of the building as it is being constructed.
That is a brilliant way to phrase it. It is a beautifully orchestrated system.
It really is. So let us begin at the absolute genesis of patient care, the very first point of contact. Phase 1, assessment.
The gathering of the intelligence.
I view this as the rigorous detective phase. The entire mission here is the systematic gathering, verification, and communication of vast amounts of data.
You are establishing a comprehensive baseline database concerning the patient's current level of physiological and psychological wellness.
You also need their historical health practices and their previous pathological vulnerabilities.
Because the baseline is the foundational anchor of all medical care. Without a robust baseline, you are flying completely blind.
The literature consistently demonstrates that nurses, due to their continuous proximity to the patient, are almost always the first practitioners to detect subtle deteriorations in a patient's condition.
The highly trained skills of physical assessment are the exact instruments used to detect those microscopic shifts before they become macroscopic emergencies.
Let's break down the types of assessments, because you're not subjecting every patient to a grueling 2-hour physiological interrogation every single time you walk into the room.
No, you would never have time for that.
Right. We have the initial comprehensive assessment, which is the massive data gathering operation that occurs upon admission.
The admission assessment is exhaustive. It is a full evaluation of every major biological system.
Neurological, cardiovascular, respiratory, gastrointestinal, integumentary, you name it.
You are establishing the normal for this specific individual.
Which is crucial, right?
Oh, incredibly. If you do not explicitly document that a patient has a baseline resting heart rate of 45 beats per minute because they are a marathon runner, a subsequent practitioner might panic.
They might initiate emergency pacing protocols entirely unnecessarily.
Exactly. The baseline provides the context for all future data.
Okay, so once that massive baseline is established, the practitioner shifts to focused ongoing assessments. If the comprehensive assessment is casting a massive net into the ocean, the focused assessment is using a highly calibrated sniper rifle.
That is a perfect distinction. A focus assessment zeroes in on a specific anatomical region or biological system where symptoms are actively localized.
Give me a clinical example of that.
Imagine you are conducting routine rounding, and you observe that a patient is exhibiting an elevated respiratory rate and using accessory muscles in their neck to breathe.
They're struggling for air.
Yes, you do not initiate a full neurological and gastrointestinal exam at that exact moment. You apply critical thinking, recognize the immediate threat to oxygenation, and perform a focused respiratory assessment.
You auscultate the lung fields with your stethoscope, listening for the exact mechanical nature of the failure.
Are there crackles indicating fluid in the alveolar spaces? Are there wheezes indicating severe bronchoconstriction?
Or consider pharmacology. If you administer a potent antihypertensive medication, your focused assessment 30 minutes later is simply utilizing a sphygmomanometer to measure the blood pressure.
You are hunting for a very specific piece of data to evaluate a very specific intervention.
Now, as the practitioner is conducting these investigations, they are categorizing the clues into two fundamentally different buckets. We have subjective data and objective data.
This is a massive concept to grasp.
Let me offer an analogy to separate these concepts. Think of a commercial airliner mid-flight. Subjective data is the cabin crew calling the cockpit to report that the passengers are feeling anxious and that someone claims they smell smoke in the back of the plane.
Okay, I like where this is going.
Objective data is the pilot looking at the instrument panel, reading the altimeter, the cabin pressure metrics, and the thermal sensors in the cargo hold. Both streams of information are vital, but they represent entirely different types of truth.
The aviation analogy perfectly captures the dichotomy. Let's translate that directly to human biology.
Let's do it.
Subjective data is the internal, unobservable experience of the patient. It is information that can only be verbalized by the person experiencing it.
Like nociception, right? The perception of pain.
Entirely subjective. A practitioner cannot look at a patient and definitively measure their pain level on a scientific instrument. We cannot attach a sensor to their forehead that reads severe anxiety or crushing nausea.
We are entirely reliant on the patient's self-reporting of their internal state.
Exactly.
So if subjective data is the passengers reporting smoke, the objective data is the instrument panel.
Precisely. Objective data consists of the verifiable, measurable, and observable metrics gathered during the physical examination. It is empirical evidence.
Meaning multiple practitioners can look at the same piece of objective data and arrive at the exact same measurement.
Yes. It is the systolic and diastolic numbers flashing on the cardiac monitor. It is the presence of an erythematous rash on the epidermis. It is the audible, mechanical sound of a heart murmur through a stethoscope.
It is undeniable.
If a postoperative wound is leaking purulent exudate, which is pus, that is objective. You can see the fluid, you can measure its exact volume in milliliters, and you can culture it in a laboratory to identify the specific bacterial strain.
And a pilot would never ignore the cabin crew reporting smoke just because the thermal sensors haven't registered it yet. And they wouldn't ignore a failing engine just because the passengers feel fine.
You must synthesize the subjective human experience with the objective empirical metrics to achieve a holistic understanding of the organism's health.
Where is the practitioner sourcing all this telemetry from, though?
Well, the primary and most vital source of data is always the patient themselves. Provided they are conscious and cognitively intact, they are the ultimate authority on their own subjective reality.
However, medicine frequently operates in less than ideal conditions.
Yes, it does. If a patient arrives unconscious following a severe trauma, or if they are suffering from advanced dementia and cannot communicate effectively, the practitioner must immediately pivot to secondary sources.
This includes interviewing family members, consulting with significant others, paramedics who are on the scene, and exhaustively mining the patient's historical medical records.
But here is the aspect of the assessment phase that I find most compelling, and arguably the most difficult to actually master in practice.
What is that?
Gathering this data is not like plugging a diagnostic cable into a machine and downloading a spreadsheet. The extraction of subjective data relies entirely on a highly complex human interaction.
You are not interrogating a hostile witness.
No, you are attempting to establish profound trust with a terrified stranger in a matter of seconds. The psychological component of the assessment phase cannot be overstated.
Because before you even touch the patient, you must initiate a therapeutic relationship.
The practitioner must introduce themselves clearly, state their clinical purpose, and project an aura of absolute trustworthiness, competence, and discretion.
And they must accomplish this while maintaining a professional, relaxed, and decidedly unhurried demeanor.
Which is incredibly hard.
Yeah, maintaining an unhurried demeanor sounds nearly impossible. When you are managing a patient load of 6 highly acute individuals, your phone is constantly ringing, and another patient is demanding pain medication down the hall.
It is one of the most difficult skills in all of clinical practice, but it is an absolute necessity.
Why is it so critical?
Because patients are incredibly perceptive. If you rush into the room, avoid eye contact, stare exclusively at your computer screen, and rapid-fire questions like you are simply checking boxes on a bureaucratic form, the patient will immediately detect your impatience.
And their psychological defense mechanisms will engage.
Exactly. They will not feel safe sharing highly sensitive, potentially stigmatizing health history.
And if they withhold that information, the entire care plan is built on a foundation of lies.
Exactly. A patient might deliberately conceal crucial subjective data, such as admitting they are currently struggling with severe substance abuse, experiencing intimate partner violence, or failing to take life-saving medication because they cannot afford it.
They will hide it if they do not implicitly trust the practitioner.
By controlling your own physical presence, utilizing direct eye contact, sitting down to ensure you are at eye level rather than powering over the bed, and modulating your tone of voice, you dismantle those psychological barriers.
The practitioner's demeanor is the key that unlocks the most critical subjective data.
It really is.
Okay, so the detective work is complete. The practitioner has successfully merged the art of human empathy with the science of empirical measurement.
They have gathered a mountain of subjective complaints, objective vital signs, and historical context.
Now they face the next monumental hurdle. They must synthesize that raw data into a coherent narrative. They must name the enemy.
And that brings us to the second phase of the architecture, which is diagnosis.
The diagnostic phase represents the pinnacle of critical analysis, doesn't it?
It does. It is the process of taking the massive clustered database of raw information, hunting for physiological and psychological patterns, and identifying the highly specific health problems that require intervention.
We need to pause right here and draw a massive neon line in the sand, because this is where the general public and, frankly, even some healthcare administrators become deeply confused.
It is a major point of confusion.
The immediate assumption is, wait a minute, diagnosing diseases is the exclusive legal and professional domain of physicians. What on earth is a nursing diagnosis?
It is a paramount distinction to make, and the taxonomy we use matters deeply. Only physicians, surgeons, and advanced practice providers formulate medical diagnoses.
Okay, so define a medical diagnosis for us.
A medical diagnosis identifies the specific underlying pathology, the disease process, or the structural failure of an organ system.
So when a physician writes congestive heart failure, type 2 diabetes mellitus, or stage 3 carcinoma, they are naming the pathological enemy.
Exactly. The entire medical model is built around curing or managing that specific disease.
If the physician is targeting the disease, what exactly is the nurse targeting?
The nurse is targeting the organism's reaction to the disease.
Oh, that is fascinating, the reaction.
Yes. A nursing diagnosis, which is rapidly evolving into the term patient problem statement to foster better interdisciplinary collaboration, identifies the patient's unique, holistic human response to that specific health condition.
Or their acute vulnerability to developing a negative response.
Right, the human response. That is a massive paradigm shift. It means the focus is not on the cellular mutation itself.
So the focus is on the human suffering caused by the mutation.
Let's contrast these two approaches with a concrete example to make it clear.
Please.
Let us examine a patient who has just received a medical diagnosis of advanced pulmonary malignancies, lung cancer.
Okay, a devastating diagnosis.
The physician's focus is on the pathology. They prescribe aggressive regimens of chemotherapy and targeted radiation to eradicate the malignant cells.
Right.
The nurse, utilizing critical thinking, looks at the holistic impact of both the disease and the toxic treatment on this specific human being.
So what do the resulting patient problem statements look like?
They might include severe activity intolerance due to compromised lung capacity, profound anticipatory grieving, acute nausea related to the chemical toxicity of the treatment, or severe anxiety regarding their mortality.
So the nurse is not attempting to cure the lung cancer. The nurse is deploying interventions to manage the catastrophic human responses triggered by the cancer, ensuring the patient actually survives the treatment process.
It is an entirely different axis of care. The physician treats the broken lungs, but the nurse treats the hypoxia, the panic, and the inability to function.
How exactly is one of these problem statements structurally built? Because it clearly isn't just a single word jotted down on a chart. It seems to require a very specific, logical syntax.
It requires a highly rigid syntax to ensure absolute precision. A properly formulated problem statement is constructed using what the literature refers to as defining characteristics.
What are those?
These are the specific, verifiable clinical cues, signs, and symptoms that provide the absolute evidence that the identified problem actually exists in reality, not just in theory.
Walk us through the mechanical anatomy of a complete problem statement.
Let us dissect a very common clinical scenario. A complete problem statement reads like a mathematical equation. Here is the example.
Okay, I'm listening.
Constipation related to insufficient fluid intake, as evidenced by increased abdominal pressure, no bowel movement for 5 days, and straining with defecation.
Let's break that down into its constituent parts because it is incredibly specific.
It leaves zero room for ambiguity. First, you have the problem label itself, which is constipation.
Right.
Second, you identify the related factor, which is the suspected etiological cause of the problem, so related to insufficient fluid intake.
That is crucial because it dictates the intervention, right?
Exactly. If the cause was a neurological spinal cord injury, the intervention would be entirely different than if the cause is simply dehydration.
That makes perfect sense.
Finally, you have the defining characteristics introduced by the phrase as evidenced by.
And this is where you plug in the subjective and objective data you gathered during the assessment phase.
Yes, the measurable increased abdominal pressure, the historical data of 0 bowel movements for 5 days, and the patient's subjective report of straining. Problem plus cause plus verifiable evidence.
It forces the practitioner to prove their logic.
Yeah.
You cannot just guess that a patient is constipated. You have to document the physiological evidence supporting your claim.
You absolutely do.
Now, are all of these diagnostic statements focused on pathological crises that are actively occurring in the present moment?
No, and this is where the predictive power of critical thinking truly shines.
Oh, predictive power. I like that.
The example we just dissected is an actual problem. The physiological failure is happening right now, but a massive component of nursing is proactive defense.
Preventative care.
Therefore, practitioners also formulate potential or risk problem statements. These describe severe physiological vulnerabilities that will inevitably develop into actual problems if the practitioner does not initiate preemptive interventions.
Give me an example of anticipating a failure before it happens.
Consider a patient who has suffered a massive stroke and is now completely paralyzed on their right side and confined to a bed.
Okay, very common scenario.
They do not currently have a pressure ulcer, a bed sore. Their skin is perfectly intact today. But a critical thinker understands the mechanics of capillary compression.
They know that the sustained weight of the patient's body against the mattress will quickly obliterate blood flow to the skin over their bony prominences.
And that will cause tissue necrosis. Therefore, the nurse formulates the statement, potential for impaired skin integrity related to physical immobilization.
They identify the catastrophic risk, and they build a care plan to prevent the reality.
Precisely. Additionally, there are health promotion diagnoses, which focus on identifying a patient's readiness to actively enhance their own baseline wellness, such as a desire to improve their nutritional intake.
So the intelligence has been gathered, the data has been synthesized, and the specific human responses have been accurately identified and named.
The practitioner now knows exactly what they are fighting.
Which means the next logical progression brings us to phases 3 and 4 of the architecture: outcomes, identification, and planning.
If assessment is gathering the intelligence and diagnosis is identifying the enemy, then this phase is setting the ultimate destination and drawing the highly specific tactical route on the map to get there.
Outcomes identification is the collaborative process where the practitioner and the patient negotiate and establish the expected outcomes.
Or the specific goals that will resolve the identified problems. And let me tell you, these goals are subject to incredibly strict criteria.
You cannot just throw vague hopes into a medical record, can you?
No, the goals must be entirely patient-centered. They must be physiologically realistic given the patient's underlying pathology, and they must be highly specific.
Let's talk about the danger of vague goals. If a patient is admitted with a massive systemic infection and the nurse writes the goal as the patient will feel better, what is the mechanical flaw in that logic?
The primary flaw is that feel better is a purely subjective, nebulous concept that is utterly impossible to measure empirically.
How do you evaluate better?
Exactly. Better than they felt an hour ago. Better than they felt last week. A goal must be explicitly measurable and strictly time-bound. Otherwise, you have absolutely no mechanism to evaluate the efficacy of your interventions.
So what would a professionally formulated goal for that infection look like?
It would sound like this. The patient will maintain a core body temperature below 99 degrees Fahrenheit, and their white blood cell count will return to a normal range within 48 hours of initiating intravenous antibiotic therapy.
Wow, that is incredibly precise.
Or, regarding pain management, the patient will independently rate their pain at a level of 3 or below on a 1 to 10 numeric scale within exactly 30 minutes of receiving the prescribed analgesic medication.
Those are definitive, empirical destinations. You will know with absolute scientific certainty whether you arrived there or failed.
Exactly. Once the destination is locked in, we move to the planning phase.
But here's the immense cognitive challenge of the planning phase. What happens when the map is overcrowded?
It happens all the time.
Imagine an intensive care scenario. You have a single patient who presents with 10 different catastrophic problems simultaneously.
Very realistic scenario.
They are experiencing crushing chest pain, they are terrified and hyperventilating, they have a massive laceration on their leg, and their family is screaming in the hallway.
Total chaos.
How does the human brain prioritize that chaos? How do you decide which problem to attack in the first 10 seconds?
This is where novice practitioners freeze and experts excel. It requires ruthless clinical prioritization. The framework utilizes Maslow's hierarchy of needs as the ultimate sorting algorithm.
You must evaluate the problems based on their immediate threat to the organism's survival.
Yes. Life-threatening physiological needs absolutely unconditionally supersede all other concerns.
This is the classic airway breathing circulation paradigm.
Precisely. It does not matter how profound the patient's psychological trauma is, or how badly they need education on their new diabetes diagnosis.
If their airway is obstructed or their cardiovascular system is collapsing and they cannot perfuse oxygen to their brain, they will be dead in 4 minutes.
You address the physiological failure first. Once the airway is secured, the breathing is stabilized, and the blood pressure is restored, then and only then do you move up the hierarchy.
To address their safety needs, their acute anxiety, and their long-term psychosocial coping mechanisms.
The problems are triaged into high, medium, and low priorities.
So the problems are triaged, the specific goals are established. Now the practitioner must select the actual weapons they are going to use, the interventions.
And these are not just random ideas pulled from a hat. They must be anchored in evidence-based practice.
Every single action taken in a modern healthcare facility must be defensible by current, peer-reviewed scientific literature.
During the planning phase, the practitioner selects a customized suite of interventions, and these fall into 2 distinct categories based on professional autonomy.
Independent interventions and dependent interventions. The dividing line here is autonomy and the legal scope of practice. An independent intervention is an action the nurse can initiate purely on their own clinical judgment without requiring a physician's permission, correct?
Correct. Independent interventions are highly potent actions that fall entirely within the scope of nursing practice.
Like what?
Deciding to implement a strict turning schedule every 2 hours to prevent tissue necrosis in a paralyzed patient is an independent intervention. Elevating the head of the bed to facilitate better lung expansion for a patient struggling to breathe is an independent action.
Or teaching a newly diagnosed diabetic patient the mechanics of drawing up insulin.
Yes, teaching is an independent critical intervention.
And the dependent interventions.
Dependent interventions require a formal legal order from a licensed healthcare provider, like a physician, a surgeon, or a nurse practitioner.
The nurse utilizes critical thinking to evaluate the appropriateness of the order, but they cannot originate it.
Right. Administering a highly toxic intravenous antibiotic, initiating a blood transfusion, or dispensing scheduled narcotics are dependent interventions.
We also need to zoom out for a second and look at the macro-level planning, because healthcare is an incredibly complex, multi-billion-dollar logistical machine.
It really is.
How do concepts like clinical pathways and managed care integrate into this individualized planning phase?
They are mechanisms designed to apply population-level critical thinking to individual patients.
Explain what a clinical pathway is.
A clinical pathway is a highly standardized, multidisciplinary blueprint that maps out the exact sequence of clinical interventions over a highly specific timeline for a particular surgical procedure or disease.
So if a patient's admitted for a routine knee replacement,
the clinical pathway dictates exactly what the physical therapist does on day 1, what pain management the nurse implements on day 2, and what the discharge criteria are on day 3.
and managed care, specifically case management, is the logistical oversight of this pathway.
It ensures that the care provided by a dozen different specialists is highly coordinated, ensuring optimal clinical outcomes while simultaneously preventing the catastrophic waste of finite healthcare resources.
It ensures the transition from the surgical suite back to the patient's home seamless.
Exactly.
So the strategic blueprint is flawless, the goals are measurable, the priorities respect the fragility of human life, and the interventions are scientifically validated.
But a blueprint cannot cure a disease.
No, a map is entirely useless if you refuse to drive the car. And that means we have arrived at the fifth phase, implementation.
This is the friction of execution. This is the physical doing of healthcare.
Implementation is where the theoretical plan collides with the physical reality of the patient.
It involves the direct physical execution of the selected interventions in a manner that is both highly efficient and profoundly safe.
It encompasses administering life-saving medications, performing complex sterile procedures, constantly monitoring the physiological telemetry,
delegating appropriate tasks to unlicensed assistive personnel, and continuously counseling the patient.
I think of the implementation phase, like a pilot flying a commercial airliner through a severe storm.
I like this analogy.
You completed all the pre-flight checklists during the planning phase. You have a filed flight plan. But the moment you are in the air, you do not just activate the autopilot, walk away from the controls, and read a novel.
Definitely not.
You are continuously scanning the horizon, reading the rating, feeling the vibration of the yoke, and instantaneously adjusting the flaps to compensate for violent turbulence.
That analogy perfectly illustrates the danger of robotic task execution. Implementation is not simply reading a list of orders and blindly executing them.
It requires hypervigilant, continuous assessment.
Because the plan was written based on the patient's condition an hour ago, the patient's biology may have fundamentally altered in the intervening 60 minutes.
If you blindly execute the order without critically analyzing the patient in front of you, you become the instrument of harm.
Let's look at some high-stakes clinical scenarios that demonstrate this exact friction.
Let's do it.
Consider the classic penicillin scenario. The practitioner is preparing to execute a dependent intervention, administering a potent dose of penicillin that was legally ordered by the physician.
Okay.
They have the syringe drawn up, they are standing at the bedside. But as they pull back the patient's gown to access the intravenous line, their continuous assessment reveals a rapidly spreading, angry red rash across the patient's chest.
Oh, wow. Okay, so what does a practitioner functioning on autopilot do?
Someone devoid of critical thinking would simply look at the order, look at the drug, and inject it, arguing that they were just following the doctor's orders.
But a critical thinker instantly recognizes the physiological implications of that specific rash.
They understand the mechanism of a severe hypersensitivity reaction. They realize that injecting that antibiotic into a patient who is actively demonstrating the early cutaneous signs of an anaphylactic allergy could trigger total cardiovascular collapse.
And airway swelling within minutes.
Yes. The critical thinker uses their cognitive framework to override the autopilot. The action they take is actually a non-action.
They actively withhold the medication.
Exactly. They prioritize the patient's immediate safety over completing a scheduled task, and they instantly contact the physician to alter the plan.
It is the cognitive discipline to know when not to act.
Exactly.
Let's look at another common friction point. Patient refusal. The plan states the nurse must administer a powerful prescribed laxative at 0800 hours.
Okay.
The nurse enters the room, and the patient adamantly refuses to take the medication.
The robotic response is to become frustrated, attempt to force compliance, or simply document patient non-compliant and just walk away.
But the critical thinking response is to launch an immediate, focused investigation to uncover the why.
Right. If the nurse interviews the patient and discovers they have experienced 6 episodes of severe liquid diarrhea throughout the night, the entire clinical picture changes.
Radically changes.
The nurse realizes that administering a laxative to a patient who is already actively losing massive amounts of fluid and electrolytes through diarrhea would be clinically disastrous.
It would exacerbate dehydration and potentially trigger lethal cardiac arrhythmias due to potassium loss.
So the patient's refusal was entirely justified by their changing physiology. The nurse holds the medication, documents the critical variants, and updates the assessment database.
And then there's the scenario that I think is the absolute masterpiece of this entire discussion. It beautifully encapsulates the tension between relying on advanced technology and relying on the practitioner's brain.
I know exactly which one you're talking about.
Walk us through the mechanics of the pulse oximeter scenario.
This is a scenario that separates novices from experts every single day in hospitals. A nurse is managing a patient with a history of complex, chronic respiratory insufficiency.
Okay.
As part of their continuous assessment, the nurse places a pulse oximeter probe onto the patient's index finger to measure the percentage of hemoglobin saturated with oxygen in their arterial blood.
Right, the little clip on the finger.
Yes. And after a few seconds, the digital monitor flashes a terrifying number, 87%.
Oh, wow. Which is a catastrophic number.
Mm.
The alarm bells in the practitioner's head should be deafening.
That number indicates severe hypoxia, which typically demands immediate, potentially highly invasive emergency interventions like forced oxygenation or even intubation.
So the machine is screaming that the patient is dying.
Precisely. But this nurse is a master of critical thinking. They do not treat the monitor, they treat the patient.
They immediately correlate the objective data from the machine with their real-time physical assessment.
Right. They observe the patient. The patient is sitting up comfortably, conversing in full sentences without any signs of respiratory distress.
The nurse utilizes their stethoscope and auscultates the lung fields, and the air movement is robust and completely clear.
There is no cyanosis, no blue discoloration around the patient's lips. However, during the physical examination, the nurse touches the patient's hands and notes that they are ice cold.
So the data streams are engaged in a massive contradiction here. The highly advanced computer is signaling a lethal event, but the biological organism appears perfectly stable. How does the nurse reconcile that?
They reconcile it by understanding the underlying physics and physiology of the technology they are wielding.
Walk me through the physics.
The nurse knows that a pulse oximeter functions by shining specific wavelengths of light through the capillary bed in the finger. However, when a patient's hands are profoundly cold, the body's sympathetic nervous system initiates severe peripheral vasoconstriction.
It clamps down the blood vessels in the extremities to shunt warm blood back to the vital organs in the core.
Exactly. And because the blood vessels in the finger are clamped shut, there is insufficient pulsatile blood flow for the machine's light sensors to read accurately.
So the hypoxia is an illusion created by cold hands.
Yes. So the critical thinker recognizes the mechanical flaw in the data gathering.
What is their intervention then?
They bypass the compromised peripheral circulation. They detach the probe from the freezing finger and apply a specialized sensor to the patient's earlobe.
Why the earlobe?
Because it is an area with a significantly more robust and reliable capillary blood flow that is far less susceptible to temperature-induced vasoconstriction.
And what does the new data reveal?
The earlobe sensor immediately registers a normal, healthy oxygen saturation of 93%.
The empirical data now perfectly aligns with the physical assessment.
If that practitioner had lacked the foundational knowledge of vasoconstriction, or if they had simply reacted blindly to the flashing red number on the monitor, they would have triggered a massive, terrifying emergency response.
Subjecting the patient to completely unnecessary and potentially dangerous medical interventions.
Instead, their disciplined framework protected the patient from the technology.
That is just brilliant. It is the ultimate proof that $1 billion of medical technology is absolutely worthless without the critical thinking of the human being interpreting the output.
It really is.
So the interventions have been masterfully executed. The medications are given, the alarms are silenced, the therapies are delivered. But the process is not over.
No, it is never over just because you did the task.
How does the practitioner actually know, beyond a shadow of a doubt, that the strategic plan actually functioned as intended?
That absolute demand for proof brings us to the final phase of the architecture: evaluation.
Okay, evaluation.
This is the rigorous process of measuring physiological success and closing the cognitive loop. Evaluation is the ongoing, deeply analytical process of determining whether the highly specific, measurable goals established during the planning phase have actually been achieved by the organism.
Let me push back on the psychology of this phase, because human beings hate being wrong.
We really do.
We all suffer from confirmation bias. When we build a plan and execute it, we desperately want to see evidence that our brilliant plan worked. What happens when the patient does not meet the goal? Let's say the goal was to reduce the patient's pain from a 9 to a 3, but an hour after the intervention, the patient is still agonizing at a level 8.
Okay.
Does the practitioner view that as a personal failure? Does it mean the nurse was incompetent in their planning?
It is absolutely vital to strip the ego entirely out of this phase. Failing to achieve a clinical goal is not viewed as a moral or professional failure.
What is it viewed as?
It is scientifically categorized as a variance. A variance simply means that the extreme complexity of the patient's biology did not respond to the intervention in the statistically anticipated manner.
The organism is dynamic, and the current strategy is failing to force the desired physiological adaptation.
Right. It is not a failure, it is just new intelligence. It is raw data demanding a change in tactics.
The identification of a variance immediately triggers the critical thinker to launch a forensic interrogation of their own process.
They interrogate every prior step of the architecture. Was my initial baseline assessment actually comprehensive, or did I miss a subtle clue?
Did I accurately diagnose the root human response, or was I treating a symptom?
Was the goal I set actually realistic for a patient with this specific comorbidity? Did I allow sufficient pharmacological time for the intervention to reach peak efficacy?
Or, most commonly, has the patient's underlying pathology mutated, creating entirely new problems that are sabotaging the current plan?
The practitioner is holding a mirror up to the actual outcome and comparing it against the desired destination.
When they conduct this forensic analysis, what are the mathematical conclusions they can ultimately reach?
There are 3 definitive conclusions a practitioner can document during the evaluation phase. Conclusion 1, the goal was completely achieved.
The patient's pain is at a verifiable level 3, and the intervention was a total success.
Yes. Conclusion 2, the goal was partially achieved. The patient's pain decreased from a 9 to a 6, but stalled before reaching the target of 3.
Meaning there is measurable physiological progress, but the current intervention lacks the necessary potency for complete resolution.
Exactly. Or, conclusion 3, the goal was entirely unachieved. The pain remains locked at a 9. The intervention was completely ineffective.
And this is where the sheer genius of this architectural framework is fully revealed. Because if you were using a linear checklist, an unachieved goal would be the end of the line.
The checklist is finished. The patient is still suffering. Game over.
But this is not a line. It is an infinite circle.
That is the absolute magic of the loop. If a goal is unachieved or only partially achieved, the practitioner does not simply give up.
The variance acts as a slingshot that hurls the practitioner immediately back to phase 1, assessment.
They re-enter the room. They gather entirely new data based on the failed intervention. They investigate the physiological reasons for the variance.
They use that new intelligence to formulate a vastly more accurate diagnostic statement.
They engineer a completely revised strategic plan with far more aggressive interventions, and they execute the new assault.
And they will continue to cycle through that relentless loop of assessment, diagnosis, planning, execution, and evaluation until the patient's physiological stability is fully restored.
Or until the pathology is definitively managed. It is an engine of continuous, iterative, scientific improvement.
It is truly a staggering cognitive achievement. It takes the absolute, terrifying chaos of failing human biology and imposes a ruthless, logical, and infinitely adaptable structure over it.
It really does.
As we begin to close out our exploration of this framework today, I want to leave our listeners with a final, slightly provocative thought to carry with them.
Oh, I'm always open to a provocation.
We have spent the last hour dissecting how highly trained medical professionals utilize this system to save lives. But the underlying psychological principle we have uncovered is completely universal.
It absolutely is.
The architecture of the nursing process proves that true, elite-level expertise is never just about accumulating a massive internal database of facts. Having the knowledge is useless if you cannot deploy it under pressure.
True expertise is possessing a disciplined, unshakable cognitive framework that allows you to apply that knowledge efficiently when the environment becomes completely unpredictable.
So I challenge you to examine your own reality. Think about the most complex, chaotic problems you are currently facing in your career, your business, or even the friction within your personal life.
How might your outcomes transform if you ruthlessly applied this exact algorithm?
What if you demanded a rigorous, objective assessment of the actual facts before reacting? What if you forced yourself to clearly diagnose the root cause of the friction, rather than just treating the immediate symptoms?
What if you insisted on planning highly specific, measurable goals, executed your interventions with absolute precision, and most importantly, possessed the humility to conduct a brutally honest evaluation of your own failures?
What if you stopped floating aimlessly down the river of your daily challenges and finally picked up the paddle and started thinking with a purpose?
That is a profoundly powerful translation of the concept. The structured application of critical thinking will elevate literally any discipline it touches.
Absolutely.
But we must remember that for the practitioner standing at the bedside, this is not a corporate optimization strategy. It is the razor-thin margin between life and death.
And while the 6 rigid phases of the nursing process provide the indispensable architectural scaffolding, the true art, the actual magic of clinical practice, occurs entirely within the practitioner's brain.
During the terrifying friction of each one of those phases.
Which means our journey into the mechanics of the medical mind is far from over. Where exactly does this architecture lead us next?
Well, to be continued. In our next session, we will take this foundational framework and transition directly into how all of these continuous iterative loops culminate in the ultimate, highly coveted clinical skill, the mastery of clinical judgment.
Oh, that is going to be an absolutely incredible discussion, and we cannot wait to dive into the deep end of that topic. Thank you so much for joining us for the Nursing Launchpad program, right here on the Licensed Practical Nurse Launchpad channel.
We hope we have fundamentally changed the way you view the chaotic world of healthcare.
Remember to stay fiercely curious, relentlessly question the data in front of you, and always keep thinking with a purpose. We will see you next time.